Well, thank you. I'm Hugh Taylor, and I'm going to talk to you about a new drug that leverages the immune system to treat endometriosis. Endometriosis is a very common disease that affects about 10% of reproductive age women. It's where the normal lining of the uterus, the endometrium, grows inside the abdominal cavity, where it causes bleeding, inflammation, scarring that can lead to debilitating pain and infertility. Where does this tissue come from? Well, normally the lining of the uterus is shed in every menstrual period where it flows out of the body. But a few cells normally flow backwards up into the abdomen where they are efficiently cleared by the immune system. In women with endometriosis, there is a defect in this immune clearance. Those cells persist, invade, and cause all of those problems. So we aim to reactivate the immune system a way that no one else is looking at treating this disease. It's essentially treated by broad hormonal suppression that doesn't really target anything specific to the disease. It affects, again, 10% of reproductive age women. That translates into about 190 million women worldwide. It takes us right now about 7 to 10 years to diagnose this disease, but that's changing. There are new innovative ways to diagnose it, and I think the market is poised to grow considerably as we diagnose this disease earlier. It's about a $120 billion economic burden in the US alone. The current therapies, as I mentioned, don't actually target the cause of the disease. We suppress every reproductive hormone. We give birth control pills or progestins, which cause a lot of side effects, but fail half of the time. They're not a good treatment option. After that, we use agents like GnRH antagonists that suppress all reproductive hormones, put women in menopause. There are a lot of negative side effects, hot flushes, bone loss. The FDA is really concerned about that bone loss and limited the use of these drugs to 6 to 12 months. Patients don't like these treatments. Surgery is another treatment. It can get rid of the endometriosis, but it grows back. There's no long-term solution. So I have been in this space for about 30 years, working on developing a better understanding of endometriosis and new treatments for endometriosis. I've partnered with Rena Yan, a Blavatnik fellow and immunologist, so we have nice complementary expertise. And we plan to target one of the receptors with an antibody that leads to this suppression of the immune system, reactivate cells that we know, immune cells that we know are less active in women with endometriosis and allow these endometrial implants to grow. It's a different approach from hormonal therapy, and it really addresses the cause rather than just suppressing the symptoms, really gets rid of the disease. So this is non-hormonal, doesn't have all the effects on bone health, doesn't change somebody's hormone balance. It targets the lesions directly, gets rid of them. It's compatible with fertility treatments because it's not suppressing the entire reproductive axis. It reduces the lesion burdens without surgery. It can clear these lesions. And it is, again, a first drug that will target the actual mechanism of action, the pathophysiology of this disease. For clinical proof, we've developed a mouse model where we create endometriosis. We suture endometrium into the abdominal cavity of the mouse. We allow it to grow for 4 weeks to establish. We treat it with our antibody for another 4 weeks. This is what we've seen to date. We get about a 70% reduction in the lesions after just 4 weeks. The lesion attachment scores are decreased, so they're not as adherent. We show that we are decreasing, again, that inhibitory receptor activity. We are increasing the activating receptor activity, and we show that some of the products of these immune cells are increased granzyme B, ICAM1, showing that the mechanism of action is we predict. This is about, again, 190 million women that are affected, 9 million in the US. If 50% fail first-line therapy, that's 4.5 million. We project about a 10% market penetration in the first few years. I think that's a very conservative estimate. Women hate the current treatments, and they really aren't effective long-term. There are other drugs in the space and other companies developing and attracting investment in developing new drugs in this area. We plan to use the 30,000 that we're asking for here to further develop our animal model. We will demonstrate dose response. We used what we thought was the optimal dose and got a very good response, but we will look to see a full dose response. We will look for the maximal tolerable dose. We saw no adverse effects to date, but we're going to screen that more carefully. And we're going to include pain measurements. That's the most bothersome symptom in women. We show the lesion shrink. Pain measurements usually correlate nicely with the lesions going away, but we'll prove that. Again, we're doing this with a commercially available antibody. We will also develop an antigen screen for new antibodies. If we get a second tranche of funding, that's where we're going to do our big screen to develop novel antibodies. That will be the basis of the Yale IP that will come from this. So thank you, and ran over a second, but take questions.
Questions from the judges? A couple of...
Question about animal model. I'm sorry, I didn't see you.
Yeah.
Animal model, this is your own model. What models have been used in clinical trials, in human clinical trials?
In human clinical trials, I mean, we select patients who have...
No. But this is your own model, so it's not been used in human clinical trials to date. But other models, are there other models that, animal models?
There are other animal models. I've used 3 different animal models. This is our standard first one because it's very easy as an initial screen. We also use skid mice where we put human endometriosis into the mouse, and I think that's another nice way to test if human disease responds the same way. I've used the non-human primate models as well, baboon models of endometriosis. I haven't found them to be any better than the mouse models, to be honest. So I think we don't need to do non-human primate testing.
Are there any risks in activating the immune system with the target that you're going after?
Of course, that's a concern. We think that it is suppressed in women with endometriosis. We want to restore the normal activity rather than enhance immune activity beyond normal. We did not see any adverse effects in our animal models, but that will be part of what we'll do with this first tranche of funding is just make sure we're not seeing any safety effects.
And then further to that, do you have an understanding of how much you're going to need to tweak the immune system? So, when this being suppressed in women with endometriosis, is there a spectrum in terms of how much suppression you have in women? Are you going to have to think about that as you're developing this as a therapeutic?
Yeah, it seems to be the levels are fairly consistent in women when we've looked at this and some of our preliminary screens. Yes, of course, there'll be some tweaking, and there may be like other drugs available in the endometriosis space, low and high doses used for severity of disease. Absolutely, we'll think about incorporating that, but I don't think it's as big as a risk as you might think.
Very exciting. More just a broad question about the space. It seems so obvious that the immune system should be targeted. Why do you believe that it hasn't been targeted until now?
That's a great question because this is an immune inflammatory disease. It has just been so much easier to suppress every hormone. It's treating the symptoms. It's really just making the disease dormant. It doesn't clear the disease. I wish people had. I think we just didn't have enough background knowledge, basic science to understand the immune defects in endometriosis and to pick a target such as the one we found here. It's been, again, I've been in this space for 30 years doing a lot of research. It took us a while to figure this out, so it's not always obvious to everyone.
Thank you.